a salad of good and bad news. So good news, Steph and I are both here today. I wasn't able to make it last week. Bad news, we both have something later in the hour where we're going to have to wrap up sooner than usual. But some good news again, I don't think anybody has ever actually minded an educational session ending a little bit earlier. So Steph is about to join us from home, and she actually had a case, a more abbreviated case that she wanted to share. So we've got that taken care of. But if someone is willing to discuss that case with me, I would very much love the company, and we can have either one or two discussants since it's both a shorter case and a shorter hour. And I also will skip any spaced learning, but I do strongly recommend the neuro VMR from yesterday, which was a case of hyperglycemic hemichuria that I learned a lot from. So you guys should go back and watch that, or at least review the teaching points, which were also beautifully captured by the other team members. Okay, I see Steph. I think I've introduced the setup, Steph, for everybody, and we're just waiting for one person to join me discuss this abbreviated case, which, if I understand correctly, Steph, is mostly focused on lab interpretation.
Yeah, it's an abnormal lab. We really pondered in a guy who was admitted for other reasons, but would love to hear your guys' thought process on it. Okay,
so let's do this. I just need one buddy. I would love for it to be someone who is a woman, but beggars can't always be choosers. So somebody step up and we'll get right into it. All right, let's do it, Anne-Marie.
Yay, looking forward to consulting you, Anne-Marie. This will be great. All right. Yay. All right, so, okay. And Zavin, what target end time are we going for? Just like a little bit after 12:30?
Yeah.
Okay, perfect. So the abnormal lab that I'd love you guys' diagnostic reasoning on is an acute on chronic CK elevation, creatinine kinase elevation. So let me give you a little backstory first, but then this will be the first aliquot. This is an 86-year-old gentleman who has a fairly advanced dementia syndrome, some mild COPD, who actually during the terrible storm we had a couple weeks ago was admitted for hypothermia, actually just due to the cold weather, a minimum temp of 88 degrees Fahrenheit with associated bradycardia, hypotension, sent to the ICU, rewarmed, got much better. After being on our service a couple days where we were working on getting him, rehab and treating a possible pneumonia, his CK, even when he remained at a normal temperature again, rose from about 500 in admission up to 1,000 to 2,000 to a peak of 5,000. And looking back in his record, all the way back since 2007, so 14 years prior, he had intermittent CK elevations from around 1,000 to 6,000. Let me stop there.
Cool, thanks, Steph. What are you thinking, Anne-Marie?
Wow, that's definitely quite the history. So I think if the first thing is when something comes back abnormal, definitely seeing kind of if it's been checked again and what's the trend. And just because it's been abnormal for a long time doesn't mean that there's not serious pathology perhaps at play that maybe has just been missed or attributed to other things. So it doesn't mean that you can just say like, oh, it's been abnormal a long time, I'm not going to worry about it, but it does change the context and kind of how you approach it. So I would be really curious, like, first of all, just thinking back, I would look back and see what had been done in the past. What, like, if there had been any evaluation done in the beginning, kind of what was the thought in the past to the CK elevation. I would also be like looking back at medication history and everything like that, seeing kind of what medications had been on in the past and any changes. And then kind of I would be also looking if other labs had been checked at in the past, if an aldolase or other signs of muscle pathology had been checked in the past as well. And then I'd also be thinking about what the correlation was to the physical exam findings, because a CK elevation and in itself, I do think of it as like muscle pathology and things like that, but it doesn't give me a lot of kind of clues as to what would be driving it. So I'd really want to correlate with the physical exam as well to say, like, how would I be approaching this? And so, and then also like a really good history of any sort of inflammatory conditions, anything like that. So those would be kind of the things I would just be thinking about to start out at.
So many fantastic points. I was thinking kind of along those same lines, and I'll just highlight like what Anna Marie said about the importance of not trying to reinvent the wheel. And one of my friends and colleagues here, Pratik Kulkarni, always just emphasizes like how much of diagnosis he feels like is just reading the medical record and taking advantage of like both the factual, like objective information there, just the fact that Steph, you guys were like looked back and were able to see that this has happened so many times before. Like, don't take that for granted. I think a lot of people wouldn't necessarily think to trend all the way back like that. But then also to look back at the notes and see what the opinions were about this and what the thinking and workup was, so that you just have a head start, right? So I think that was really critical to emphasize. It seems like this patient's kind of course surrounding this problem is characterized by like intermittent episodes of more kind of acute and severe rhabdomyolysis, although 5,000 isn't like terrible. For example, it's not at a level where you would expect to have really serious electrolyte abnormalities or kidney injury and stuff. So it's like an episodic worsening, right, on top of some chronic process or some chronic predisposition. On the one hand, in an acute setting, you definitely want to manage the acute episode, especially if it's severe. But then it's like an acute discovery of a chronic process doesn't make it an acute process, right? So the framework changes completely to think about what could cause these episodes for such a long period of time without otherwise like manifesting itself fully, right? And I think, most of the differential though for muscle injury, whether it's, electrolyte abnormalities, like hypokalemia, hypophosphatemia, whether it's medication use, whether it's hypothyroidism, and on the one hand, like you would expect some of the like hypothyroidism, like would you really be hypothyroid for 13 years? First of all, maybe. Second of all, you don't have to be constantly hypothyroid, right? Like what if he was on and off his thyroid medication? Same with the electrolytes, right? You could have episodes of, dehydration and hypokalemia, as well as just like dehydration itself isn't good for muscle function, especially when associated with hyperthermia and things like that. It's not necessarily that you have to be like sustained hypokalemic for 13 years, right? There may be some background genetic predisposition to muscle injury, or some chronic non-genetic predisposition to muscle injury, like vitamin D deficiency, that this patient very well could have had for the last 13 years. And then when there's a second hit, that's enough to actually precipitate, the next episode of rhabdo or worsen the CK elevation or whatever. And just moving on, thinking about some of the other causes, Anne Marie mentioned, inflammatory conditions, right? Could this be a myositis, whether independent of other organ involvement, or could it be part of like a mixed connective tissue disorder? You know, the longer I do this, the more I think I'm seeing this phenomenon that a lot of you know, auto-inflammatory conditions that we at least I was initially sort of thought were, you know, sort of very progressive, that as a natural history do tend to have this sort of ebbing and flowing course of remissions and exacerbations even without, you know, immunosuppressive therapy. So I wouldn't necessarily take that off the list either. So I've been rambling for a while. I think Anne-Marie captured a lot of fantastic points, and maybe just to move the case forward, Steph, back to you. What else do you want to tell us?
Yeah, let me give you some more history. And this was very true to life. I was just crossing my fingers the CK was going to just go away and start going down every day. And so it was only when it started climbing did we really look back. So let me give you some more history, as well as some of the pertinent past medical, and then I'll go right into the exam for him before kind of giving you the labs as a last aliquot. The CK elevation, as I said, had been noted since 2007 with really no workup done. One discharge summary from a hospital admission at which it had gotten at its highest, around 6,000. You know, it wasn't the main reason he was there, same as this hospital is saying. They queried whether it could be due to prolonged immobilization, and it was left at that. And then otherwise, no focused evaluation had happened as he popped in and out of the system over the decade after. And it wasn't always 6,000. Very often it was like close to 1,000, but nothing so striking, I think, that it prompted a big workup. His, I'll just say his functional status had declined over the last, let's say, several years also. He lived in a group home. As I mentioned, he had dementia. But he had become progressively weak with being able to stand up, and over the last couple of years was in a wheelchair and could not even stand up out of the wheelchair to, you know, transfer to his bed. He needed help with that. Although on history, he had no issues that he was aware of with combing his hair or kind of brushing his teeth, elevating his arms. He had a completely negative review of systems for inflammatory systems that could go with a rheumatologic diagnosis. So no arthritis, no skin changes or mouth ulceration, hair loss, no dyspnea or respiratory symptoms at all, really no signature of other systemic rheumatologic disease. And he was on a statin during this time period. I don't know when it was started, but it had been started prior to 2007. His other medications were for COPD. There was nothing else relevant. And there was no known family history of myopathy, and no relevant work or trauma, social history, nor alcohol or substance use that could play into this issue. And then I'll just give you a very focused exam, which is his vitals were normal. So his temperature had remained normal since he had been rewarmed in the intensive care unit. Everything else was normal limits. And then, you know, really just focusing on sort of musculoskeletal, he's an 86-year-old guy, so he did have decreased muscle mass everywhere, but it was nothing striking. There wasn't profound cachexia or wasting, but he was sarcopenic, but he was 86. It wasn't without the realm of what's normal for someone who's older. But he definitely had proximal muscle weakness with maybe at best 4- strength with shoulder abduction, adduction, flexion, extension, but was 5 out of 5 peripherally. And I'll say for the lower extremity, very difficult to say. Again, he was in bed, you know, he was more deconditioned because of the acute hospital stay, but couldn't even like really kind of, if we sat him up in bed, couldn't even like try to sort of, you know, scoot himself, or what do I mean? Make any effort to stand up at all. Anything else on the exam you guys would want to know? That was really sort of the pertinent focus we did. And again, no signature of joint inflammation, no arthritis, skin changes, skin mucosal ulcers. I see
And
Alex
I-
asking
and
about pain. He actually had no pain at all. That's really critical. Through all of this, he had no muscle discomfort at all, either on exam or when you asked him plainly.
any signs of hypothyroidism on exam, dry skin, anything like that. Okay.
Nope. And then heart rate was normal for what that's worth as a hypothyroid signature.
And I don't know if you'll get to this later, but was the hypothermia on admission thought to be due to cold exposure or? Okay,
Yes.
I just wanted to clarify that.
Yep. All cold exposure.
Okay, so I think now we have some exam findings and some history, which are going to help direct us because CK elevation in general is really broad. And so when I'm thinking about it, I'm always going to want to know, first and foremost, like what the muscle exam is like, any inflammatory rashes or anything like that that would change the differential, and then also looking for other organ involvement. So now I'm going to say, okay, this is an 86-year-old man with proximal muscle weakness that is, so severe that it's limiting the movements, as well as diffuse sarcopenia that has been ongoing for 14 years on a statin. And so with that, I'm going to try to build a differential from that. So thinking about proximal muscle weakness, I want to be thinking about what could be kind of the mimics of an inflammatory myopathy that could be going on here. So I'd be thinking about, could there be some sort of neurologic disease that is basically, so severe that it's causing, muscles not to be able to move and causing the sarcopenia. Other things that could be thinking about that would be less likely in someone of his age would be some sort of muscular dystrophy, but you would expect that to manifest far earlier. And then kind of related to that would be like some sort of metabolic myopathy, like a mitochondrial disease, something like fat metabolism that caused abnormalities. But again, these are things that I would expect to manifest far earlier than this. I'm also going to be thinking about things like myasthenia, things like that, but without bulbar or cranial nerve symptoms and just proximal muscle weakness, that seems very unlikely in this case. And then thinking about like infections, making sure that an HIV has been checked, making sure that we know the immune status, immunocompromised, immunocompetent. In Houston, this seems less likely, but you could, think about things like parasitic disease, Lyme disease, things like that. If it were an immunocompromised host, thinking about, other infections that could affect the muscles like toxoplasmosis. A lot of viral etiologies can also affect the muscles. I've heard about, I saw a case of severe rhabdomyolysis caused by COVID-19, but also, other viral infections, EBV, CMV can do it too, as well as things like Staph aureus, strep can sometimes cause an infectious myositis, things like that. Although with the time course, there could be an acute on chronic, but I'm thinking it seems less likely because, here we have something that's been going on a really long time. So unless there's something that was kind of a chronic thing and then we have an acute thing that's worsening the chronic thing, that seems a little less likely in this situation. And then, a really good review of the medication list. Some of the things that I'm thinking about would be making sure, looking at the steroid history. If someone had been on steroids for a long time, sometimes you can see a myopathy, although you don't usually get the CK elevation with that. So it seems less likely, but always, a good thing to review. And then thinking about statins, fibrates, things like that. So he's been on a statin a long time. I would want to know exactly what the statin was because some statins are more predisposed to causing elevations than others. But I think the first step in this situation, if it had been going on a long time and was elevated and there was weakness, I would stop the statin in this situation and then assess response to that. You can also get a necrotizing myopathy from statins. And so I think that's something to be thinking about is, you know, with necrotizing myopathy, usually you see more profound weakness and higher CK elevations. It sometimes is more painful as well. So not forgetting that as well as just kind of statin-induced myopathy, sometimes you can get a necrotizing myopathy related to statin use, although it can occur independently, which is to do with antibodies against the HMG coenzyme A receptor antibody. And then also going to be thinking about things like endocrinopathies as well, like hypothyroidism, someone who's bradycardic and hypothermic. It sounds like it was maybe just cold exposure and that hasn't persisted, but thinking about was, you know, a thyroid function tested? Is there any other signs of hypothyroidism? It does not sound like hyperthyroidism based on the clinical exam here. Hyperparathyroidism, and then, you know, vitamin D deficiency as well. And then electrolyte disturbances. So low phos can sometimes lead to CK elevations, and someone who has malnutrition, perhaps that could be contributing to really reviewing the labs, making sure phos has been checked, as well as a calcium and vitamin D. And then also kind of seeing like, maybe there's something at play, but, you know, with the lack of movement, could there be some sort of acute thing that's precipitating the worsening of that as well? So those would be kind of the things I would be thinking about trying to look through as I was examining the patient.
Anyway, that was beautiful and extremely comprehensive. For a while, I was like, oh wow, she's covering like everything. Maybe I'll mention the statin-induced autoimmune, you know, necrotizing myopathy, but you got that too. So that was amazing. I really have nothing else to add.
Let me fill in some of the labs then, because yeah, Anne-Marie, that was just beautiful. Wish you were on the team with us. That really kind of informed a lot of our differential and what we worked up. So I will clarify, the statin was atorvastatin 40 milligrams. So that's what he had been on for a long time. In terms of labs, CBC, normal. On the chemistry, I will specifically highlight just a couple of the electrolytes. Everything else was normal. The potassium was appropriately a little bit at the upper limit of normal when he was having a lot of CK released in his blood. It was probably up to 5.1 or so. And then when it all improved, the potassium came to normal limits. And there was also an appropriate elevation of phos when he was releasing a lot of muscle contacts to maybe upper 5s. And that came down to normal limits when the process improved. His BUN and creatinine through all of this remained normal. He did get treated with isotonic fluids when that CK started getting near 5,000. The TSH was normal. The 25 hydroxy vitamin D was the best I've seen in anyone in a long time. It was 66, which is healthily in the normal range for our lab. He had an ANA, an anti-nuclear antibody that was 1 to 40, homogeneous pattern. Had a mild aldolase elevation to 25. I think upper limit of normal was 10. He had a anti-Joe scent to look for inflammatory myopathy that was normal. And was there anything else you guys had asked on workup that you had in mind, Anne-Marie or Zavin?
Were there inflammatory markers sent?
Oh, he had an ESR that was 67. I do not remember the CRP, but I don't think it was remarkably high. So the ESR was a touch elevated.
And was there, you said the anti-Joe and ANA, was there like a full myositis panel and like necrotizing myositis panel center? No.
No, because once we kind of got some of these back, and we'll tell you, the CK started coming down very nicely. It hit 5,000 and then just started going away. We ended up not broadening the inflammatory myopathy workup at that time.
Okay. Zavin, do you want to take this? I feel like I talked a lot last time.
Sure. I mean, I still don't have too much more to add. You know, the statin-induced myopathy, exactly as you said, tends to be more fulminant and often is diagnosed. But maybe those are the cases that we actually diagnose, right? Maybe there's, and just to be clear, everybody, this is like an immune process that is triggered by the statin, and then it's autonomous even once you stop the statin. But I wonder if it's possible to just have a lower grade fluctuating, you know, disease that doesn't get immediately, you know, biopsied and diagnosed, and maybe that's what we're dealing with here. You know, the other thing I'd emphasize is Steph kept saying the potassium was appropriately elevated, phosphate was appropriately elevated. And that's really important. I've seen several cases where someone comes in with like legit rhabdo, you know, CKs 15, 20, 50,000, and the potassium is like 3.8. 4.1, and we don't find any other source. And of course, you know, when you go into rhabdo from bad hypokalemia, hypophosphatemia, you know, the potassium is still going to leak out of the cells into your serum, and it's going to hide the hypokalemia, right? Whereas the hypokalemia was in fact the original trigger. And then once the muscle injury stops, and with all the fluids and stuff, suddenly your potassium's, you know, really low. So that doesn't seem to be happening here either. So I think the ESR is borderline elevated for a man his age, still pretty non-specific. I don't know. I mean, I feel like I would at this point I would talk to this guy and say, you know, just think about how much is this actually bothersome. Like, he's weak, but I would also wonder how much his weakness improved once the, you know, CK improved. And to think about getting a muscle biopsy to see if there's some inflammatory and thus possibly treatable process there. But in the context of everything else, it may or may not be worth it for him if he feels like, you know, he has these episodes. Sometimes he's a little weak, sometimes his pee is a little dark, but then it's no big deal and it gets better in a couple of days, right? Yeah, I think in the end, I would probably, you know, and just to also make a comment about some of the genetic conditions that have been mentioned. So there's the dystrophinopathies, right? And those, even, what is it? There's Duchenne's and there's Becker's, right? Duchenne's is severe. It always presents in childhood. Becker's can be young adulthood, but those aren't happening in an 86-year-old man. Then there's the metabolic disorders like, you know, the McCardles and Pompe's and all those things we hated memorizing for step one, right? And those two can sometimes be diagnosed later in young adulthood. But usually, you know, you have some kind of, you know, episodes of hypoglycemia or hepatomegaly. Like, I don't know enough about those conditions, but I would just be really surprised if somebody with those not only made it to 86, but made it to 86 without being, you know, diagnosed in some way or having other kind of vibes of a systemic metabolic syndrome. So there's that. And then I really think there are these other sort of genetic predispositions to muscle injury. You know, they're just, you know, these people that we see sometimes who come in with very little exertion, not a whole lot of overheating in the summer, and they have major, you know, rhabdo, and this is their like 5th episode. They're otherwise young and healthy and don't take any medications. There's nothing else wrong with them. And the workup is always negative. And you know, I think there's a lot we don't know, and I suspect that there's a lot of, you know, genetic polymorphisms and stuff that just predispose to muscle injury with a lower threshold than in most people. So that's all the additional thoughts I kind of have about what might be going on with him, as well as what we might do about that. What do you think, Anne-Marie?
Should we mention why, you know, we haven't mentioned inclusion body myositis yet, which in his age demographic would definitely, especially with like kind of this slow insidious, would be kind of something thinking about. Should we kind of go through maybe why we thought less so that to be the case in this situation? Or I can maybe say like what I think, not that I'm an expert on it.
Please, yeah, because that of all of the inflammatory myopathies, that was the one that I thought fit best demographically. Would love to hear your thoughts, and then I can give you the resolution, which isn't a complete resolution at all, but I'll tell you what we ended up doing.
Yeah. So my thought on this was initially when I had heard the first aliquot, I thought, could this be inclusion body myositis? Generally with inclusion body myositis, it is both proximal and distal. And so the fact that there's no distal involvement made me think this is probably less likely. notably compared to the other ones, there's less, or it can be more asymmetric than the other ones, always something to keep in mind. And the CK elevation usually isn't super high. It's usually just very like a smidge, like mildly elevated, like about 10 times the upper limit of normal. So kind of my thought was, with the lack of distal involvement and with the degree of CK elevation, another explanation with the statin, it seemed less likely in this case. But I would welcome if anyone else has any other thoughts, because I'm certainly not an expert on it.
We were totally on the same page. His age was something else that fit the illness script pretty well. That is one of the inflammatory myopathies that happens more common in older, but his pattern of weakness, the elevations being rarely very high, just didn't quite fit. But I'll tell you, he doesn't have a diagnosis yet. So what we ended up doing is we stopped the statin in case that was just part of the background issue at all, and without a clear ongoing therapeutic indication for it. The actual elevation itself peaked at 5,000 and started coming down. He got some fluids for renal protection and it all got better. His functional status kind of remained at what his baseline was, which was wheelchair bound, but he was able to go back to his group home. But before he left, we had rheumatology see him, and they ultimately did not think an inflammatory myopathy fit for many reasons, but mostly the long time course, as well as the elevation really never getting up to the tens of thousands, which they thought would be much more typical for that. But they appreciated the other metabolic workup we did and scheduled him for an outpatient EMG. But their clinical concern is that ultimately it could be an underlying primary neuromuscular disorder in the background of actual muscle degeneration, as opposed to a driving inflammatory process. So he doesn't have a diagnosis yet. He will get an EMG, see rheumatology again with labs rechecked, but they were pretty inclined to start involving neuromuscular specialists in his case, wondering if he had an underlying, just as you guys were thinking, genetic or other just degenerative condition predisposing him to these bouts of elevation when he was otherwise sick for other reasons. No final diagnosis, but really loved hearing your guys' thought process. Really beautifully done. Zavan, any?
Thanks for.
Oh, I'm so sorry.
Thanks for sharing the case, Steph and Anne-Marie. Really fun discussing with you. I'm unfortunately going to have to excuse myself, but Anne-Marie, please make any additional points or discussion you were going to make. And then Chiara, I think you were taking notes. Would love for you to summarize them for the audience too. I was just looking through them, and it's a great little recap. But I just want to thank everybody and say goodbye and see you next week, hopefully.
Thanks, Zavan.
Thanks for discussing with me.
What were you going to say, Anne-Marie?
My only thought is that if it was still elevated at follow-up after he was off the statin, I wonder would be worth it to send the necrotizing myopathy panel for the HMG coenzyme A antibody, just because that can persist after the statin is stopped.
Absolutely. I think that's an important point that, correct. Stopping the drug doesn't fix that process. It was interesting, even for that diagnosis, the impression was the peak elevations were never quite in the range expected for any of the inflammatory myopathies, the HMG co-reductase inhibitor antibodies also, but that'll be an important point to suss out once he's truly been off the statin for a while. Awesome. Well, thank you for just sharing the thoughts on it. It was kind of fun to do a mini case of kind of a single abnormality within a guy who was, sick for other reasons. And Sukriti, I think you're doing teaching points. We can turn it over to you for wrap up.
Thanks, Steph. So today we're teaching points. I'm going to try to summarize them in sort of 5 points, similar to what Core IM podcast does with their 5 clinical pearls. So thinking about the first was, we thought about how we could approach the CK elevation equating it essentially to muscle injury. And so Anne-Marie taught us before doing this and thinking of the buckets, it's important to think about the mimics of inflammatory myopathy. So thinking about severe neurologic disease, muscular dystrophy, metabolic myopathy, and abnormal fat metabolism. Then we come to really the core of the symptom, creating a framework that consists of the infectious bucket. An important branching point here is whether the patient is immunocompromised versus immunocompetent, because your etiology changes in terms of thinking of bacterial causes like staph and strep in immunocompetent patients, and maybe more atypical organisms like EBV, CMV, parasites, and now the very prevalent SARS-CoV-2 as well. The next bucket is to think about medications, especially statins and fibrates. Zavin and Anne-Marie also laid down an illness script about statin-induced necrotizing myositis. So how would we frame this illness script? Basically, it's a severe acute onset proximal muscle weakness. So it's essentially a fulminant disease. It's autoimmune, so there are antibodies against this HMG-CoA reductase. I'm not sure if Anne-Marie, please correct me after I'm wrong, if the antibodies are against HMG-CoA reductase, and you find that these patients have really high elevations of CK. And Zavin mentioned that this disease is autonomous even once you stop the statin, so the injury continues even after you stop the medication. Coming back to the framework in which we discussed the muscle injury, we also talked about endocrinopathies like hypothyroidism, hyperparathyroidism, as well as some of the metabolic causes consisting of hypokalemia and hyperphosphatemia. This case was especially useful in thinking about how we may approach an episodic worsening of chronic muscle injury. And Zavin essentially equated this to the hit hypothesis that we think about in oncology. So the first hit could either be something that genetically predisposes somebody, like an electrolyte abnormality in the voltage gated channels, versus something that is non-genetic, like a vitamin D deficiency. So we also talked about this genetic predisposition to muscle injury in a little more detail, and we thought about this in three buckets essentially. The first was something like a dystrophy, thinking about mainly Becker's that's diagnosed in a young adult versus Duchenne's, which is usually in a child. Then the second, metabolic, so thinking about glycogen storage diseases. And the third that Zavin mentioned was essentially an increased susceptibility to muscle injury, either as a consequence of heat. And we also discussed the illness script for an inclusion body myositis. So this is an inflammatory muscle disease that occurs in older adults. And as Anne-Marie mentioned, it's usually it involves proximal and distal muscles. And it's important to note that this is asymmetric, and the CK elevations are usually mild, so only about 10 times the upper limit of normal.
That was wonderful, Sukriti. Thanks to everyone for being here today. I appreciate your flexibility with a mini case and just getting to share something interesting that I got to work through in real life recently. And what a great reference on inflammatory myopathies in the chat that hopefully all of you guys got to see. Have a wonderful rest of the week, and we look forward to seeing you next Wednesday. Have a good afternoon. Bye.